So for the last presentation of today, before we go actually into the body of corpus, Dr. Barend Mees with aortic surgery. We had him before on our yearly day, and I'm looking forward to the pictures and the movies. It's a subject that interests us most because it's the most threatening about having a Marfan aortic surgery. Dr. Barend Mees.
Thank you very much. Indeed, it has been, I think, 2 years ago that I've given a presentation to the Dutch Marfan Patient Society on one of their days, and at that stage I admitted that I was quite nervous because I was used to give presentations for large or small audience very on a scientific base to my colleague surgeons, but I've never done that before, or I did never do it for patients, and especially not patients with Marfan disease who are so involved with their disease and who have so many aortic problems that we see. And I asked the same question as I would like to ask today. Who has already been operated for his aorta? So at least half of the people in the room. So some things you will recognize from your own operations, and some other things will be new, and some things you will be facing in the future. Because one thing that is sure is that Marfan disease and aortic surgery is a lifelong relationship. Unfortunately, I would say, but as long as we are able to deliver the optimal result, I think that would be great. I will give this presentation also on behalf of my colleagues in Maastricht and Aachen, which is one large center with 2 locations. And one of the things I will say to you is that it's only possible to treat these diseases if you have a great team. Just to start off with, the prevalence of connective tissue diseases, Marfan is the most common, but we, of course, as aortic surgeons, see also the other connective tissue diseases. And the cardiovascular complications that I will discuss today in Marfan disease are aortic root dilation, aortic valve insufficiency, aortoiliac dilation, aortic dissection, both type A, type B dissections, and Torico abdominal post-dissection aneurysms. But as a surgeon, it's obligatory to start with the anatomy. So the anatomy of our vascular system consists of arteries and veins. Arteries that bring the oxygen-rich blood to our organs, and the veins who will bring back this blood to the heart. It is in real life exactly as in the drawings. Veins look blue and arteries look pink. Maybe not as red as on the drawings, but they look pink. So you can see a lot of the same kind of figures in the body, and I will go through the most important arteries for Marfan disease. So arteries are elastic, especially the large arteries that are most commonly involved in Marfan disorders. This is because they have a thick, strong vascular wall. And this wall consists of 3 layers. The intima, which is just usually one cell layer of endothelial cells. These cells are the messenger cells. They feel what's happening in the blood and give signals to the wall and to the muscle cells or the other cells in the wall to adapt. For example, to relax and dilate, or to constrict, or to constrict and then also constrict the vessel. In the media, there is elasticity, but mostly muscle cells. And in the adventitia is the layer that brings actually the strength to the vascular wall. In Marfan, on the left is a normal, above A and B is normal vascular wall, and below is a vascular wall of a Marfan patient, where there is fragmentation of the elastic fibers, which means that the wall of the artery is not as strong as in normal people. So mostly the aorta is involved. And if we start looking at the aorta, the first part of the aorta that leaves the heart is the aortic root, which encompasses the aortic valve. And from the aortic root, the coronary arteries, the arteries for the heart, evolve. They are close to the heart. Then you will appreciate here the coronaries, and then the ascending aorta, the aortic arch, and the descending aorta. And the arch runs a little bit from anterior, from your front to the back. So the descending aorta is very close to the spinal column. It's all the way at the back of your body. That's why if you have if there is a tear or something else with your aorta descending, you can feel pain in the back and in the shoulders. The same is true for in the abdomen, in the tummy. It lies all the way to the back. So to reach it, you have to pass all the abdominal organs for a surgeon. So the most important branches from the aortic arch, they are of course essential because they perfuse the right arm, the right brain, usually coming off one trunk, then the left brain, or the left side of the brain, and the left arm. If we go down from the descending aorta, we go towards something that we call the Torico-abdominal aorta. Thorax is chest and abdomen is tummy. The Torico-abdominal aorta has very important branches that perfuse the organs in the belly. So there's one that perfuses the liver and the spleen and the stomach. Then there is a large artery that perfuses all the intestines, 2 arteries for the kidneys, and one smaller one for the other intestines. So if we see a normal population and look at aortic dilation, then more than 80% of people who have an aortic aneurysm or an aortic disease have this in their abdomen. So more than 80%. This is completely different in patients with Marfan disorder who have predominantly their disease in this part of the aorta, but also in the remaining of the aorta. So what kind of diseases or events are common in Marfan disease? One of those is an aneurysm. And an aneurysm is a local dilation of an artery, a sort of a bulge. And the definition of an aneurysm is if there is an increase of the normal diameter of more than 50%. So a 2 centimeter aorta, when it becomes more than 3, you can call this an aneurysm. And this is a picture of an aneurysm. This is a rather secular aneurysm. This is not a Marfan patient, where you can see a bulge, but actually the aneurysm is the dark bit that you see, which is the outer wall with some thrombus inside. And why is an aneurysm caused? Because of artery wall weakness. And there's several causes for artery wall weakness. One is degenerative. So age, smoking, high blood pressure, and male are risk factors for normal population to have or to get an aneurysm. And this is called degenerative. These are probably 90% of the aneurysms that we see. There is an aneurysm after a dissection, which I will show you later. You can have aneurysms after a trauma, which I mean usually a trauma made by a doctor. For example, a doctor that has catheterized the aorta and made a little hole in the first layer, and there is a bit of weakness, and later on an aneurysm. Infection may cause an aneurysm because the wall gets weak because of the bacteria that are in there. And finally, connective tissue disease, which is the cause in Marfan patients. This is a CT scan, a little movie where we start at the front of the patient and we go all the way to the back, and you can see a typical aneurysm of the infrarenal aorta, of the aorta below the kidneys. So this is in the abdomen. You can see this is the liver. The kidneys will be here, and And this is what we're talking about if we talk about an aneurysm. This should be a nice round tube, but now it's sort of a bag, a sac. So what are the normal diameters of an aorta? The root should be between 20 and 30 millimeters. The ascending aorta up to 36, just like the arch. The descending aorta is a bit smaller, and when it comes down into the abdomen, it's even smaller, 10 to 24 millimeters. So aneurysms are usually asymptomatic. You will never know that you have one until it becomes symptomatic. But an aneurysm has a risk of rupture, which we can all probably imagine, that the bigger the balloon gets, at one point the wall will be weak at one stage, at one position, and then risk of rupture. There's a risk of dissection. This means that one of the layers gets a tear, and increase in diameter means increase in risk. When there is a rupture or a dissection, people have severe pain and shock. So this is an emergent situation. Okay, the dissection. A dissection is a tear in the vascular or in the arterial wall, but only limited to 2 layers. Because if the 3rd layer would be also torn, then this would be a rupture, and the blood would be out in the open. The tear will cause a false and a true lumen, and I have some nice pictures of that to show you what I mean with that, because that's even difficult for us sometimes to understand. The dissection may proceed to rupture because there is a tear in 1 or 2 layers, so there's a chance that the 3rd layer will tear as well. And it may cause malperfusion. And this is an example of the normal artery with those 3 layers, and this is a dissected artery. And because of this dissection, you can see there is an entry tear. This is what we call the strength of the blood pressure will push the blood into the vascular wall, and in this way all the layers below, under influence of this pressure, will loosen, and you will have 2 channels in your aorta until there is another tear, which usually happens when there's a side branch, because where there's a side branch there's always a hole, so you will get, and this is where the blood comes back in the normal lumen, in the true lumen, or it runs all the way down. This is a sample of a real aorta with a true lumen and with a false lumen. And this will be now the first video with blood. So I hope that's okay. Because this illustrates extremely well how this dissection looks. This is, so this is a repair of a thoracic post-dissection aneurysm. The patient is on the left. You can see already the beating heart, and this is the aneurysm. It's like a sausage. Look at this. So it's so large. It should be a nice tube of 2 centimeters. And if we put a clamp above and below and open the aneurysm, then you will see there's some thrombus that you have to take out, because an aneurysm is always gets some thrombus. And we will show you now that here is the dissection flap. So this will be the true lumen behind, while where we're looking at is a false lumen. It's a very thick layer. So the whole 2 layers have gone to the left in the screen and have become very thick and remodeled. So this is actually to show how a dissection looks if you open this in surgery. So the end is just to show that you make a nice round aorta and then suture in a graft. Okay, was that okay? Yeah? Okay, good. There will be some more. Okay. First, to start off with, I'd like to start with the root. So we go all the way down on using the aorta as its natural course. So cardiovascular complications in Marfan, to start off with the root dilation. Root dilation is often asymptomatic. However, in patients with Marfan disease, they can be diagnosed already in their childhood, so they're followed up regularly to see what happens to the aortic root. Rarely, but it still is, or really, I think it's rarely, but maybe you can answer it. You get a patient in an emergency setting with a large aorta that wasn't diagnosed before with Marfan, but I think I'm not sure how often that happens. Anyway, the root dilation will be mostly asymptomatic, just like all the aneurysms. When it becomes symptomatic, this means that it's ruptured or it's dissected. The indication, because we're talking about surgery today, is for surgical replacement is when the diameter is more than 4.5 centimeters. That's sort of our threshold. Of course, there is differences for every patient. Is it a young and a fit patient? Can he handle an operation? But in general, this is sort of the size diameter, or if it's symptomatic.
And is it approximately the same for all the centers in the Netherlands?
It should be. It should be. Yes. I think so. Yeah. Yes, I believe so. For other countries I can't speak, but I think this is in these kind of figures will be in all the guidelines. So it would be very difficult to do something else. Here you can see an MR scan of an aortic dilatation. This is a very big root, especially compared with the arch here. And this is another example where you can see that the root is the only place which is dilated. And this can be often the case, that the rest of the aorta is still normal. So, what are the options then? The root has to be replaced. And depending on the function of the valve, also the aortic valve will be replaced. This is the total aortic root replacement, including the mechanical aortic valve, which is called a Bentel procedure. Has anyone had a Bentel procedure? Yeah. So this operation is being done under circular arrest. The heart needs to be stopped. There's a heart-lung machine that perfuses the brain, or even the patient gets made very cold to keep the brain in a sort of hibernation. And because you use a mechanical aortic valve, which is a metal thing or a plastic thing, you have to use lifelong anticoagulation tablets to keep the blood thin, because there's a high risk of clotting. How does that look? This is how it looks. So there is a graft with reinsertion of the coronary arteries, and in that graft is a mechanical valve. So we have got another option. This is called valve sparing root replacement. There's two types, Jacob and David. This has to be done also under circular arrest. However, there's no valve replacement, so one of the advantages would be that there is no lifelong anticoagulation. And in detail, these are sort of schematic pictures of how a valve sparing root replacement functions. Who has had a valve sparing operation? Okay, so. Yes, this is an example of an, let me just see if we go, yeah, we go, of an ascending aorta replacement. So this is not a Bentel, neither a valve valve sparing operation, but it's just a tube. When only the ascending aorta is involved, then you can do just a tube. And these are other types of surgery that can be done to replace the ascending aorta. A normal tube. This is called a hemi-arch. This is called a total arch replacement. And this is called a debranching. So already all the branches of the arch are being debranched onto the graft. We don't like this in Marfan patients because you leave here an island of diseased artery which has a high chance of dilating in the future. So I will show you later that if we do surgery in Marfan patients, we like to remove all the diseased tissue to have no recurrence of disease. Something new on the block is the personalized external aortic root support. This is something that we don't do in Maastricht, and I've asked my cardiothoracic surgeons what they think about it. And they say, well, it's a new technique. It's mainly done in London. It's got no long-term follow-up, but it looks as a promising technique. I'll show you how it works. There's no valve replacement. There's no circular arrest, so no heart-lung machine, and there's no lifelong anticoagulation. And it's like a wrap around the aorta. So this is a sort of personalized 3D printed kind of wrap that can be put around the aorta. To strengthen the aorta, you have to put the coronaries inside, and then you have a sort of a support from the outside. This is pictures from John Pepper, who invented this technique, I think even together with a patient, that shows you aorta unsupported compared to supported aorta. So they suggested there's even in the aorta, when it's supported around, a sort of remodeling, that it may become healthy again. And this is a picture of a patient with 10 years follow-up. So you can see that this is before and this is after the operation, and I do not see a difference in dilation of the root. So it seems to hold. In conclusion, all these operations in the ascending aorta and aortic root are very well specialized, very well done by a great cardiothoracic team. I think the cardiothoracic surgeons are one of the surgeons that work the best with standardizing techniques, because they do very large operations and have a low mortality, much lower than vascular surgeons, because maybe the operations are different, but also because they've standardized a lot of their work. They have only an early mortality of less than 2% for these operations. Sometimes some centers have zero mortality. Mortality means death during or in the first 30 days after an operation. Patients with a root replacement have a long-term survival of more than 90%. If you have a valve-sparing operation and do not have to take anticoagulation, and you do not have a thrombogenic valve, you have less events in the future, less clotting and less bleeding. And the last question is about the personalized external support. Do you have to remove the diseased aorta or not? Because you, in the wrapping technique, you keep your own tissue, which is something that we are worried about. But long-term follow-up will see whether this is a viable technique. If we go to aortic dissections, type E, type B, type A and type B. This is the classification of dissections. On the bottom it says the Stanford type A versus type B. On the top it's the Debakey Classification. Both are important American surgeons. Debakey 1 means that the tear starts in the ascending aorta, and all the way down there's a true and false lumen to the abdomen. A type 2 is isolated ascending aorta. A type 3, or A or B, means that the tear is in the descending aorta. We classify it usually in the Netherlands with Stanford in A and B, but I personally think that the Debakey is better. And A means that the tear is in the ascending aorta, and B, the tear in the descending aorta. The symptoms, this is one slide in Dutch, excuse me for that, I'll translate that. The symptoms of an aortic dissection are pain, sudden pain, very sharp pain, often between the shoulder blades, in the back or in the abdomen. There's mostly a high blood pressure, and there can be signs of malperfusion. And malperfusion is illustrated here. If you have perfusion of the visceral arteries, the abdominal arteries. By the true lumen, there's usually a correct perfusion. Sometimes there's a false and true lumen perfusion. But rarely you can see that the false lumen compresses the true lumen by the blood pressure and that there's no blood coming into the kidney or the abdomen or a leg. This is called malperfusion. This is an acute situation in a dissection. Okay, so this will probably be the last one in Dutch. So type A, you can imagine, because this is the ascending aorta, involves the coronary arteries and the brain and arm arteries. While type B dissection, down from the left subclavian, from the left arm artery, involves mainly the abdomen and the legs. And this is an example of malperfusion. So here is a normal aortic root. Here is a dissection with 2 lumina. And you can appreciate here that the kidneys do not look the same. And they should look the same because the blood should be equally divided in 2 kidneys. So this kidney is malperfused. There's not enough blood going to that kidney. So you need to do something. Here is a CT scan that runs from the top of the bottom of the patient. So we start at the head. And these things are vessels, artery, and this is the aortic arch. And you can see the tear and the huge aorta. And even here, this will be the true lumen, and this will be the false lumen. Here is another lumen. So the whole aorta has got different tears and different holes in the wall, perfusing organs or not perfusing organs. And this is an impressive image, I think. This will be the same patient. And you can appreciate the difference between the 2 kidneys. So there's one kidney that's malperfused, and it is a huge aorta where you can see a very tiny true lumen. This is the true lumen, and this large lumen will be the false lumen. Okay, an untreated type A dissection leads almost sure to death if you don't treat this. It may not be in a day, but I think the 1 month mortality is almost 100%. So you need emergent surgery. And you need a replacement of your ascending aorta. This operation is much more dangerous than the aortic root elective operations, but it still has a mortality of less than 10% or around 10%. And it's an acute operation. In general, I think everyone will understand that acute operations are always worse than elective operations because they happen at night or the patient is more sick. 2 of the main reasons why there's a worse outcome. For a type A dissection, the same kind of operations are being done, replacement of the ascending aorta. And here it is extremely important that there is a good collaboration and good knowledge of the cardiothoracic surgeon with the vascular surgeons and with the rest of the team. Because you know that in a Marfan patient there will be, because he's young, maybe more operations to come, maybe more aortic problems to come. So even at night, in the middle of the night, in an emergency situation, you should think about the next step. And one of those things that is being developed is to do a more extensive operation in the emergency setting with an elephant trunk, not tongue. This means that you replace the ascending aorta with a graft, and there's either at the end of the graft there is a stent that you put into the descending aorta, or there is a piece of graft that you put in. You don't suture this, but this will be hanging in the wind like an elephant trunk. And for all the next operations, this will be the point where you can start your next operation. So you don't have to go back in the arch. The same with this in the same operation where there's a lot of scar tissue or where there's a higher risk of complications. So this is a technique that's been done now a lot, even in the emergency settings, to prepare for the next step. So after the type A dissection, the acute situation is treated. The danger is, for now, over. However, as I've shown you, often there is a remaining dissection either in the arch or all the way down to the iliac arteries. And this dissection is a weak spot and may form an aneurysm later. And this is where, for example, Maastricht or vascular surgeons will come in for Marfan patients, because all this root and arch work is usually done by cardiothoracic surgeons, or sometimes together. So aneurysms grow faster in Marfan patients than in non-Marfan patients, and this is called the post-dissection thoraco-abdominal aneurysm, which I'll discuss afterwards. Now back to type B dissection. This is a dissection coming off from the left subclavian. And because normally the ascending aorta is involved in Marfan patients, we don't see too many of those isolated type B dissections in Marfan patients. But I've seen one 2 weeks ago. So it's less common. Even these can be complicated versus uncomplicated. Complicated will be with pain that you can't control, or high blood pressure that you can't control, or malperfusion of the organs. An uncomplicated type B dissection can be treated with medical therapy, getting the pain under control, the blood pressure under control, treating cholesterol, treating platelets, and in this way you can actually keep a lot of patients away from the surgeon, which is often a good thing. Complicated dissections need an operation, maybe not at night, but at least in the days after the dissection. These operations are often done by a stent, often endovascular, because an aorta that has just over a big length torn is a very weak aorta, and to suture this aorta and to put some graft is very dangerous, especially in this area. So this is usually done, those stents, in an angio suite is what it's called. These are operating theaters that are completely equipped with X-ray machines, where you can do both open operations as endovascular operations under X-ray. And you see everyone with protected lead. There's a lot of people in those rooms, very large operating rooms, perfectly suitable to place a stent. And a stent looks like this. And the most important thing of a stent in the acute phase is to close the tear. So it's not possible to have blood anymore through this true lumen. And in this way, the aorta, and especially the true lumen, will have no pressure anymore. Sorry, the false lumen. Correct me. So there will be no blood pressure, no big blood pressure in this area, and over time we think that the aorta may remodel and become small again. In this way, we can prevent complications at the operation. So the malperfusion will be over, because there's now one true lumen, and secondly, in the future there will be remodeling of the aorta. This is a picture of under X-ray, how those stents are being positioned, and this is the end result after the procedure. This is not very good for Marfan patients, because the aorta of the Marfan patients is weaker than the aorta of normal patients. Therefore, a stent that you put in that has radial force is going to push away the Marfan aorta and will potentially cause another tear, or maybe a rupture, or it won't hold because it will just be too small for the dilating aorta. So if you have to do this in emergency setting, it's possible, but in Marfan patients often it's a bridge to open surgery. However, this is a very new development. This is from a conference in 2017. This is what happens. There's a stent here, and you can see that at the area where the stent is, at the bottom, so here it is being put in, but later on there's another tear here because of the force of the stent. And this is what we don't want to have. So that's why in Uppsala, together with a commercial company, they developed a stent graft with the last two stents without the metal, so only the fabric. So it's sort of an elephant trunk, sort of a loose bit. And the idea is that maybe then you can put these stents in a dissection patient without creating a new tear at the bottom of the stent. So there are all kind of developments currently in this area. A type B dissection has a mortality of less than 10%, but a substantial mortality. And if it's complicated, then there's a high mortality. So, post-dissection thoraco-abdominal aneurysms. 20% of those, of the thoraco-abdominal aneurysms are post-dissection. They're often more extensive than degenerative because of the entry tier or the tier that's much longer, so they involve more of the aorta, and they're frequently in patients with connective tissue, and so in young patients. They have a risk for rupture, and these have an indication for surgery when the diameter is over 6 centimeters. However, in Marfan patients, we have an indication for surgery when it's over 5 centimeters. This can be treated with open surgery and endovascular surgery. This is how these aneurysms look and are classified from type 1 till type 5. And you can imagine that in patients with a type A dissection, you will see mostly these most extensive aneurysms. And here, let me see, here is an image of a large aneurysm that runs all the way to the abdomen, just like here. These are type 2 thoraco-abdominal aneurysms. This is one type of treatment, repair with side grafts. And this is another one using stents that are custom made exactly on the anatomy of the patient. So what is the current treatment of these post-dissection thoraco-abdominal aneurysms? And why am I here? Because this could be told by a lot of different vascular surgeons, but I am very lucky to work in Maastricht and Aachen, and we are an aortic center. We receive complex aortic aneurysms from the whole region, and we even receive from the whole country, both in Netherlands and in Germany, aneurysms in the arch and thoraco-abdominal aneurysms. We don't treat all the arch aneurysms and thoraco-abdominal aneurysms in the Netherlands, but we have received from Groningen to Soest to Goes, for example, patients. And we also have international patients from countries where they don't do open thoraco-abdominal surgery. This is called the European Vascular Center. And what you need to have in these kind of centers is a lot of information about the patient. There's a lot of questions to answer before you can say what treatment is best. And this is why we have these kind of weekly meetings with cardiologists, cardiothoracic surgeons, intensivists, anesthetists, and we look at the whole patient and then decide which treatment would be best for this patient. We've done some work on how to treat patients together with the. Do I see? Okay, yeah. So here is some of our own publications, but there's also written things about aortic disease in Marfan on stent grafting, because that's what I first want to share with you. And the first sentence in 2005 was already that in general stent grafts should not be used in the aorta of a Marfan patient. Later on, it's technically possible to do, but it has not a good long-term prognosis. And the last paper on stents, with a combined study with 54 patients, they say you have to use these with the greatest caution. And open surgical repair has been effective. So I'd like to speak to you, and that's why we will see some nice more videos about open surgery for thoraco-abdominal aneurysms. The surgical protocol is intense. You will need a heart-lung machine. We will need to do selective perfusion of the abdominal organs during the operation. We need to protect the kidneys. There's a drain in the spinal cord to protect the spinal cord. We have neuro monitoring. I'll show you all of these later. And if possible, we would like to stage the reconstruction. So not everything at once. And this is an example of a team that does an operation like this. There will be at least 3 surgeons in the room. There will be 2 scrub nurses, usually 2 anesthetists, 2 perfusionists that have the heart-lung machine under control. There's a neurologist or a neurophysiologist looking at the spinal cord function. There will be a cardiologist or an intensivist that intraoperatively looks at the heart, and there's nurses around. And this is all to achieve the optimal result for the patient.
What is a
A scrub nurse is the operation assistant that works with the surgeons at the table and is actually the boss of the operating table, because she gives you what you ask for, or she gives you what she thinks you need. But see, those are the best, of course. So here's an example of an operating room where we will have all those features. This is a heart-lung machine. This is beforehand. We always make a drawing and put this drawing into the operating theater. So everyone knows what's the situation before and what will be the situation at the end. And this is a repair. And I'll just go back for very briefly to show you. Yeah. So this must be a Marfan case, because you can see that all the side branches have different bypasses. While usually we would do this in non-Marfan patients, we would just sew an island of aorta with all those side branches onto the graft, much quicker. This is much longer, but this is typically for Marfan. So I'd like to stress that. Okay, so this is so everyone knows what the plan is. You can see already that it's very crowded around the table. So this will be a repair of both abdominal and thoracic. Here are the two large catheters for the heart-lung machine. And this is the heart-lung machine. And this is an example of one of those bypasses that you put onto the side branches. A little bypass that will be now perfused. This is onto a kidney. And we perfuse the kidney during the operation. So on the left you see the large graft. That looks like a bit like an octopus. Here this is the large graft that replaces the aorta. And those are all separate bypasses to insert all the visceral vessels into the graft. So paraplegia after thoraco-abdominal surgical repair remains a nightmare. And this is our worst fear. Of course, to lose someone in an operation is even worse, but some people would even argue that maybe paraplegia would even be worse, because what's the quality of life after being paralyzed from the middle? And this is one of the most important risks in this surgery. Not only for the function and the quality of life, but also because it increases the chance of mortality later on, or morbidity complications. Paraplegia is not the same as spinal cord ischemia, so in literature and in the talk about it, there's a difference. Spinal cord ischemia means that there are some symptoms that may resolve, but paraplegia is really wheelchair bound. The incidence of spinal cord ischemia, so not complete paraplegia, is between 2 to 20% in these operations, depending on the extent of the operation. And even while we're using stents now, in non-Marfan patients, we could not really lower this incidence, also in the stent technique. And the dilemma during this operation is which branch to the spinal cord, because these are all coming from the aorta, should we reinsert? Which one is the most important? Because there's a lot already occluded. Some will be small but important, other ones will be large but maybe not important. You can't tell from the outside. And the blood supply to the spinal cord is very complex. The critical level for the spinal cord perfusion is mostly at this level. But some patients depend on branches of the aorta up high. Even 8% of patients will have a critical branch to the spinal cord coming from the iliac artery. And if you do magnetic resonance studies, you can see that there is a very important artery that connects the branches to the spinal cord from the aorta, which is the one that you really need to save. So sometimes you can see beforehand, but not often. This is an example of a patient with a lot of branches still patent to the spinal cord, and there's a network between them, so for sure you can miss some of them, but you never know which one is the most important. There's also patients who have already lost some of them and have only a few. So one of the important thing is that the anatomy doesn't always reflect the function. That's why it's so difficult to predict. So the way to monitor this during surgery is a technique that we've used for a long time in Maastricht, but is also being used in other centers around the world. It's called motor evoked potentials. So during the operation, we stimulate through the brain the arms and the legs. And then we get feedback from the arms and the legs if the stimulation is still intact. If you put a clamp at a level of the aorta, you will see if there's no change, that means that that part of the aorta is not important for the spinal cord. And in this way you can sort of select the area of importance. I'll show you how this works. This is a normal response. This would be an abnormal response, which means that there's a problem somewhere between the arms and the legs. So these motor evoked potentials are also depending on blood pressure, because there is a large collateral network that if you increase the blood pressure, that you may increase the perfusion through collaterals so that the spinal cord is getting enough blood again, even while its important artery is blocked. So for example here, the blood pressure is 60 millimeters. We've put a clamp and there is no change in, and there may be a decline in your motor evoked potential. You can see if you raise the blood pressure to 80, there'll be a better signal. So this is something you can do during the operation. When the neurophysiologist tells you the motor evoked potentials go down, we tell to the anesthetist, blood pressure up. So this is why this is such an important teamwork. This is during an operation while you are in the middle of suturing and working. You have to be very communicative with your team. And if at that stage there is still no increase in motor evoked potentials, even with the increase of blood pressure, this means that there is an important branch in that area that you've clamped. So we reinsert the arteries in that area, like you see here. So this is the aorta. These are very tiny spinal cord branches that you can stop the bleeding by blocking them. However, if you need to implant them, you have to do over that little balloon, you have to put a little bypass on and put that bypass either on perfusion or onto the graft. To reduce spinal cord ischemia, you really need a multidisciplinary approach. And this is 2 or 3 years ago, I think 3 years ago. This is during the EVC, which is the European Vascular Course in Maastricht. Usually 2,500 vascular surgeons come every year. And the day before we had a very, very good symposium with people from all over the world, not only surgeons, also neurophysiologists and anesthetists, to have a real good multidisciplinary discussion on how to get those paraplegia rates down. Okay, there's 2 more, guys. So another example of one of the operations. This is a CT, there's a drawing. This will be a large open Torico abdominal aneurysm. You can see here the motor evoked potential, measuring probes. Here is the electric stimulation of the brain. And this will be mainly an operation in the chest. So this is an operation coming from all the way from the arch. And there's an old graft that you can see. So this was someone who had already replaced ascending aorta, which is often the case. And then the operation needs to go up to that graft to remove all the diseased tissue in between. And here is two bypass grafts already on the brain arteries with perfusion, with a heart-lung machine. And this is the final repair. This is the spinal cord drain. So there's a punction being done. This is, I'll have to explain why this is. So if you draw the fluid from the spinal cord, this means that the pressure in the spinal cord will be low. This means that the pressure from the blood coming in will be relatively higher. Therefore, you lower the risk of paraplegia. So this is why all these patients, if there is a long part of the aorta that we have to replace, not the arch, but if it's thoraco-abdominal, they will have a spinal cord drain before the operation and for the first 2-3 days after the operation. Here you can see how we stimulate the legs during the operation. So while busy suturing, you will have sometimes the patient moving because of these motor evoked potentials. So these can be. This is the largest operation you can have. This is all the way from the iliac arteries to the arch. And it's amazing to see that even in these patients that have a replacement from here to here, only have 20% chance of spinal cord ischemia. So 80% has got perfusion of the spinal cord by other means. But 20% is very high, of course. So this is sometimes working very quickly. Here you can see different catheters that we use to perfuse the kidney arteries and the intestinal arteries. And that's why we use the heart-lung machine, because there's no perfusion now for the legs or for the visceral vessels. This is the Neuro Monitoring machine. So the motor evoked potentials will be looked at. The patient is cold. This is preserving function. And then there is a long period of suturing, different grafts to different tubes. I'll see. I think for the sake of time, it will continue. But you can see how a repair looks like this. Side branches to all the different vessels. So we have looked into the results in Aachen and Maastricht. This is very new data. We still are doing some work on this, on how the results in our center are. This is about 65 patients. So this will be probably the largest European series of thoraco-abdominal aneurysm repair in patients with connective tissue disease. So you can see that the majority is Marfan, but not all of them. And we've noticed that this is a group with very large operations. So I can't read, but 86% is Marfan. They have hypertension, and they have, all of them almost have a post-dissection aneurysm. 86% have had previous surgery. So the majority has a type 2, which is the largest aneurysm and the most dangerous and the most complicated. And this is the type of repair that we've done. So you see that we've only done 40% of type 2, while there's more of the type 2. This is staging, so you only do that area that is really necessary, because the bigger you make the operation, the more complications. It's better to do it in 2 settings than all at once. Sometimes you can't. If there's no landing zone, no normal area, you have to go all the way down, but if you can do first this bit and then later on that bit, that would be better for the patient. 11% emergencies, and this is actually real life. So with that extensive surgery and with all those emergencies, we, in the current follow-up, even have a mortality percentage of more than 10%. So it's large surgery. We thought it was a bit disappointing, but this is true. And 35% has no complications. So there's a lot of complications, bleeding that needs revision, not too many people or no people on dialysis, and the paraplegia rate of 2% is very low. If you look at survival, 6 years later, 75% estimated survival. If you have a very long operation, then you have a higher risk of not surviving. This is, of course, because very long operations are usually complicated operations. However, if the operation is done properly and you survive, then you have a long period without re-interventions. So it can be a very durable operation. And there were no revisions needed, so nobody had to have another operation in the same area. They had other aortic operations, which we know is common in Marfan disease, I think. So it's durable, but it has a significant complication and mortality rate. So is there no role for stenting? A question we always get. This is a patient that we've just recently seen that has had already 2 repairs. And here you can see that this is an aneurysm here. And on this stage you can see that this is way too straight for a normal artery. This is a graft. And on our drawing that we make, there is a graft already here with a repair, and there is a graft already here. What important is all those arteries to the spinal cord. But there is a correct landing zone here in a graft, and there is a correct landing zone here. So this patient can be treated with a stent, which makes a lot of difference. Can even be done under local anesthesia if you want. Through the groin, it's a procedure of 45 minutes, and there's a tube being positioned through the groin from the inside, from graft to graft. And because you land in a graft, there's no problem with the Marfan tissue. So there may be a role for stenting. But in general, this is sort of the paradigm for treatment of Marfan patients. An acute type A dissection has to be done open surgery. If there's a complicated type B dissection, you can put in a stent, probably as a bridge to surgery. Normal aneurysms, open surgery in Marfan patients. Post-dissection aneurysms, open surgery. If it's not possible to operate someone because he has had so many operations already, or because he's got something called this frozen chest, which means that the chest is completely scarred from previous operations or anatomical deformities, then you may have to choose an endovascular option. And of course, if stents fail, they have to be taken out with open surgery. Okay. This is just to show you that this is a very rare disease. Per 1 million inhabitants, there's 19 admissions for thoracoabdominal aneurysms. Only 11 get treated, 2 open surgery. So we all admit that it's very strange to do this in all hospitals if it's so rare. Open surgery is still the choice of therapy for almost all Marfan patients. The question is if you have to replace all diseased tissue, you need an extensive surgical protocol, and there's some options endovascularly. And already 3 years ago, the head of our department, and he will be talking about this even the coming 5 years, is about centralization. The basic principle should be that the patients deserve the best outcome, and it should not depend to choose what kind of treatment on the experience of the surgeon or the experience of the center or the local infrastructure. No, it should depend on the age, disease, pathology, and the comorbidities of the patient. And the choice for the center should depend on the experience and the infrastructure and the outcomes. And I think for all complex surgical interventions, centralization is putting patients first, and there's best results in high volume centers and high volume surgery. And this is why we do it. This is our last, or one of my last Marfan patients from Groningen, who has had already 3 operations now on the aorta, and is back to work, is happy as an optometrist, and writes pieces of paper and articles in different journals. And that's where we, as a surgeon, do our work for. Thank you. 36 minutes. Yeah. Wow. I think he had 2 maybe in the same day. But the final result was okay.
What was the average time of one surgery?
We reserve the whole day, for these kind of operations. Normally, theater starts at 8, but if the operation is so extensive, all preparations will be only finished at 9:30 when we can really start the operation, and then probably it will take you until 4 or sometimes 6. So 9. Less than 7 is good because that makes the that has less complications than over 7. Yeah. So.
Do you eat? But that was a question what I have. My surgery takes 12 hours. Do you have a break or something as a doctor? Because it's quite long. You have to go
yes.
to the toilet.
No, I think a very good question. So the question is whether we eat during the operation or have a break. We will get sometimes something to drink. We should probably take a break more often, but when you're so concentrated, you often don't notice that you are doing this for so long. But I remember in my training that, for example, in certain surgeries, not necessarily vascular surgery, the preparation of the whole operation takes already very long, and the critical bit is at the end to make the final reconstruction. So I remember that at that stage, the surgeons, just before they went for the critical part, they would say, okay, I'm going to have a cup of coffee. And they went to the coffee room, just away from the theater, and to relax a little bit and have one coffee and then come back for the critical bit. I think in vascular surgery sometimes there's no time because we have every repair you make in vascular surgery is done under clamping because you can't operate on a blood vessel while it's still blood flowing. So that's why it's a bit time dependent. And if you have the aorta clamped, it feels a bit weird to go to the coffee room. So this is in our surgery is a bit difficult. If you take 4 hours just to have everything ready for clamping, then it would be a good idea to have, before you start repairing, to have a little break. Any more questions? I think I've covered a lot, so maybe.
Yeah, also impressed.
Maybe.
Talk about centralization. Is that already the case in Netherlands?
Not officially, but unofficially, I think there is certain centralization. I think for the ascending, so the root operations that are the most common in Marfan patients, these are only done by cardiothoracic surgeons and sometimes emergency. So then you just go to the closest cardiothoracic center. For elective operations, I think what's also happening in the Netherlands because of the network is that people go to the centers where they have a good experience with, or where other patients have correct experience. So we get sometimes questions from patients in Amsterdam to come to Maastricht for a certain repair, which is not always necessary. So I think for the Torico abdominal aneurysms in Marfan patients, I think there'll be not a lot of centers doing this in the Netherlands. So Nieuwegein is a very good center, and I think Maastricht is then like Nieuwegein. But I'm not sure about other centers doing Marfan patients. They do some Torico abdominal operations, but we haven't agreed on this, and it's always very difficult discussion in the surgical land to say to someone, I think you should not do this operation anymore. And he will say, well, I've done 5 and they all went perfect. And you don't have an argument. So it's difficult. Sometimes you need help from the politics. And you should, of course, also, even if you're a large center, you should show that your results are good enough. One thing is, of course, that Marfan, there are Marfan dedicated centers, not so much surgical centers, but there is, I think, in all the most of the academic centers, there's a large Marfan outpatients, so it should be a bit connected.
If I understand it right, you also many surgeries in that?
So we've got so Professor Jacobs is actually he's the open aortic surgeon, and he works in both locations. And we have some other surgeons, like me, who travel a bit hence and forth, but not all of us. And also because not all of us have a registration in Germany. I do, but so we work together and we travel a bit. But there is the rest is quite separate. There's no anaesthetist traveling, or the local scrub nurses, and the intensive care is really local. But for example, because Germany is such a large country, they get a lot of German patients. So we sort of try to get the international patients then to Maastricht, and that's how we sort of divide. But we haven't swapped German and Dutch patients over. Maybe in the future.
Is the replacing material, is that still elastic for an aorta?
I should have brought some. It's Dacron, so it can be knitted or woven. It's polyester. It is relatively elastic. You can sort of extend it a bit, and you can pull it at length. For example, if you need to replace 10 centimeters, you can probably do that with 8 centimeters of Dacron. And if you use too much, you risk that it's going to kink again. So over time, it will evolve a little bit. But it's quite elastic to answer the question. I should repeat the question, I think. Eh? Sorry for the video.
No more questions? Thank you so much. It was very impressive,
It
impressive to watch, but also amazing to see what's possible for Marfan patients. So
It's very honor to be here. It's no problem to come all the way from Maastricht for these kind of meetings. It really is.
Okay, a typical Dutch present on behalf of the Marfan Europe Network.
Yes,
Thank you.
Thank you very much.
You're welcome.
Okay.